Looks like we are ready to get started. My name is Olivia Snyder. I'm a fourth year medical student at the University of Iowa Carver College of Medicine. And today we're going to be talking about a critical care topic. We're going to be going over brain bleeds. Before we get started, can everybody see the screen and hear me okay? I'm struggling to pull up the chat right now because I just let me try something really quick. Sorry, guys. Okay, I apologize. I'm on a different setup than I'm used to, so I'm still getting used to it. But okay, anyways, getting back to our case. My name's Olivia. I'm a fourth year med student, and I'm going to be leading us through this case on brain bleeds. So as always, we're going to start with our patient case, go through the history, physical exam, and differential diagnosis. We'll make an assessment and plan for our patient, and then we'll do at the end a lesson on the pathology of disease. I did put the link for our SOAP note and quiz in the chat, as well as our resource drive for like common terminology and things for you guys to be able to use. So make sure that's all pulled up and everything okay. This is what it should look like. I'll make sure everybody has their stuff pulled up. So we're going to start with our case. We have a 44-year-old male who presents to the emergency room with sudden onset of severe headache. He has no inciting event known or trauma that happened, and the first onset was 30 minutes ago. He's described this headache as the worst headache of his life and like a thunderclap. So with this information, what diagnoses should we consider right away, or what kind of history do we want to get to help narrow down what our diagnosis might be? You guys can either put stuff in the chat or feel free to unmute yourself. Any ideas about what could cause like a severe headache? Could be any cause. Chase is going to ask if he's on a blood thinner, if he has any other associated symptoms. Those are both awesome questions to ask. Certainly risk factor for certain things like brain bleeds would be being on a blood thinner. I'm going to challenge you guys to try to come up with like 2 causes of headache that you can think of for us to have in our differential. Migraine is one, absolutely. It's one of probably the most common types of headache that we see, especially because they can have some kind of scary symptoms that go along with it that might bring people into the ER. And then subarachnoid hemorrhage, perfect. Yes, so subarachnoid hemorrhage is one of the types of brain bleeds that we're going to go over. And it can certainly present in this way. In fact, in a lot of board style questions, a dead giveaway for a subarachnoid hemorrhage is this thunderclap headache. That's like a buzzword that they like to use. So this is just a differential that I came up with. It is by no means exhaustive, but it has, I think, like a good variety of things on it. So any sort of headache that you would think of, including some, as Chase said, migraine headache, other headaches like tension headaches or cluster headaches can also be pretty severe and can come on quickly. Something that'd be more chronic in nature that's not going to come on like in a 30-minute time span and be super severe, but still could present with a headache is like a mass or a brain tumor. And then lastly, our patient wouldn't fit this criteria necessarily because they didn't have any trauma associated with it, but just head trauma or fall in general, and having some sort of traumatic brain injury that doesn't necessarily have to have a bleed associated with it. From a vascular perspective, within the head, a brain bleed where you actually get blood, leaving the blood vessels, whether it's arteries or veins, and entering the cranium, which is an enclosed space. So you build up pressure in the head and can also have some other like mass symptoms that we'll go over in a second. Similarly, an aneurysm, which is a sort of outpouching of a blood vessel where it's normally supposed to be like a pipe, but imagine that your pipe like has like a water or maybe some tape on the side of it that's trying to hold it in place, and it starts to kind of stretch outwards. It really weakens the wall, and so you can get this sort of ballooning of the blood vessel that can cause headache. And then of course, if it ruptures, can also cause headache. And then lastly, usually strokes, which can be either ischemic, which is where you have like a blood clot or a like a blockage in the blood vessel where you're losing blood supply to that area of the brain, or hemorrhagic, where you have bleeding into the brain itself. Strokes typically, especially ischemic strokes, don't tend to present with headaches, but it's not out of the question. Other causes that I thought of maybe would be like substance use. So particularly some substance that when you withdraw from can have headaches, namely opiates, alcohol, or caffeine withdrawal even. I'm sure we've all, skipped a day of drinking our morning coffee and can have a headache in the afternoon from that. And then other drugs that can cause in toxicity levels can cause headache. Some things that we don't want to miss that haven't been covered already, things like meningitis or a CNS infection could certainly present with a headache, as well as some other symptoms that we'd want to look for, and that might not be as consistent with this patient's acute presentation, but that could still be something that comes on in a matter of hours or days. Okay, so I wanted to run through what the different types of brain bleeds are for us to consider for this patient. The first one is an epidural hematoma. And this one is usually following a trauma. It's almost always after you have a head trauma. And a characteristic of an epidural hematoma that the others don't have is something called a lucid interval, which is where the patient has, after their traumatic event, they feel initially fine. They might have normal consciousness. They don't have any pain. They just appear to be okay. But then after some time, they have an increase in symptoms, maybe head pain or change in consciousness, change in mental status that indicates that there's something severe going on. The next one is a subdural hematoma. And this is going to be also usually after a trauma, but we tend to see this more in patients who are elderly or older, and especially those who are on blood thinning medications. So that's something that we want to look at for this patient too. The third one that Chase already mentioned was a subarachnoid hemorrhage. And this can be due to traumatic causes, or it could also be spontaneous. One of the most common causes of a spontaneous subarachnoid hemorrhage is the rupture of an aneurysm that can just happen when you're sitting on the couch, when you're laying in bed, when you're sitting at a desk or something. It doesn't have to be that you have a head trauma or that you're doing any particular activity. And then the last one is an intraparenchymal hemorrhage, and this is also known as a hemorrhagic stroke. And this can be due to trauma or a spontaneous, which would be like that hemorrhagic stroke from something like hypertension as an underlying cause. So additional case details for our patient. His headache came on suddenly while he was working out in his yard. Let's say he was like mowing his grass or something. And he's never had a headache like this before in his life. This is the first time that he's ever had something like this. And his headache is not, he is not accompanied by any family or guests, so we can't gather any collateral information. Especially in neurologic cases and psychiatric cases, it's really important to try to have a collateral source of information that we can use to supplement our history, because the patient might not always have the most accurate or complete information. He rates his pain a 10 out of 10, and for his review of systems, he does also have nausea, but without vomiting, and he also has neck stiffness, and these both onset around the same time as when his headache started. All of his other symptoms or review systems are negative. So for some additional past medical history, He does not see a physician regularly, but he has been diagnosed in the past with high cholesterol, and his only medication that he takes is simvastatin, and this is a cholesterol lowering medication. For his surgical history, he had a tonsillectomy at age 9 to get his tonsils removed and an appendectomy at age 23 to have his appendix removed. For family history, his father has a history of kidney disease in quotes, but we aren't sure the specific type or cause. And the patient does report that his father had a kidney transplant, but doesn't know any more information besides that. And then for social history, the patient was a smoker for 20 years. He would smoke a half a pack per day, but he did quit smoking 3 years ago. He also drinks 4 alcoholic beverages per week, which is, I would say, like not a super high amount. It's not nothing, but it's pretty standard, I would say, for a lot of people. And he is married, has 3 kids, and he works as a teacher and also does high school swimming coaching. So that's a little bit about his social history. So this is going to be his physical exam. I wanted to give you guys a chance to look at his vitals and see if anything looks out of the ordinary to you with respect to his vitals. We've got a blood pressure of 156/90, heart rate of 82, respiratory rate of 20, temperature is 37 Celsius, which is 98 Fahrenheit. And SpO2 is 97% and BMI 32. It looks like Diana said that the blood pressure is high, which is accurate. Yes, his blood pressure is certainly high. Kind of not known right now if it's just high situationally or if he has chronic, uncontrolled, undiagnosed hypertension. But yeah, he also has some mild tachypnea, as Chase said. And those are really the 2 most remarkable ones. Like this is kind of borderline high. It's not like, oh my gosh, he's in respiratory distress, like we need to do something right away. But we do see some like sort of hemodynamic instability here. And then also his BMI is a little bit past the cutoff for obesity. So just, he's probably not in perfect health. For the rest of his exam, for his general appearance, he looks somnolent, which is sort of like a tired or like sleepy appearance. He does also appear painful, but he is cooperative with exam. For his head and neck exam, he has equal carotid pulses bilaterally, and his mucous membranes are clear. For his cardiopulmonary exam, he has a regular rate and heart rhythm with no murmurs, and then his lung sounds are also clear and equal. His abdominal exam, unremarkable. It is soft, non-tender, non-distended. And then his neuro exam is probably the most interesting part here. He is awake, alert, and oriented ×2. So he is oriented to person and place, but he is not oriented to time. So that's a change probably from baseline, and maybe even a change from when he first came into the ED, and that he's kind of, having a change in his neurologic status over the last couple of, however many minutes it's been. He also has his pupils are dilated and minimally reactive to light. So the pupil exam is important because we want our pupils to, 1, be equal in size, and we want them to be able to respond to light. So once light is shown into the eyes, you want your pupils to be able to constrict in response to light. And if they're not able to do that, or if your pupils are not in agreement with each other, then that can be an indication of neurologic compromise or problems. But he doesn't have any other focal neurologic deficits besides this. So given this exam and the history that we have, what kind of tests or imaging or labs would you guys like to order to try and further figure out what we're dealing with here? Bridget said MRI, so some imaging. CT from Chase. Would you guys happen to know like what the, like when would you get an MRI versus when you would get a CT? Just I mentioned that because CTs are very fast, and MRIs, while they give us a lot of excellent detail of the brain, it takes a long time. Like the patient has to be able to sit still and be stable for sometimes like 30 minutes to an hour, depending on what they're looking for. And MRIs are also a lot more expensive. So I do think that he would start off with getting a CT, but then a lot of times what we'll do is, especially in patients with a brain injury, we can go back and do an MRI at a later time once they're like stabilized and we are able to start whatever treatment they need. So I like that you guys are all thinking about getting imaging right now. I think that's definitely the place we want to start. Just a subtle difference between the two. So we are going to get a CT specifically without contrast. Again, this is just kind of playing into that the contrast is going to add to the time that it takes to get the imaging. So we can see areas of brain bleeds without contrast, and it's going to save us time to get him, the imaging that he needs. And then that is going to be able to further guide our treatment. So we're going to start with the CT without contrast. And then later on, we can also follow up with a CT angiogram. This is kind of the same situation as the MRI. And I think you could probably make an argument for getting an MRI as well after we get this initial CT without contrast. And it's just going to, again, confirm the findings or maybe be able to more thoroughly assess the damage that may have been caused by this brain injury and help us to kind of know long-term what we're looking at here. But for our first step, we're going to do this non-con CT. Also, we can get a CBC, BMP, and coagulation panel. So it looks like Chase did also suggest getting a CBC, which I do like, especially if we were worried about him having any sort of like infection or having like other sources of bleeding that could potentially cause an anemia or something. And then the coagulation panel is just going to show us how easily the blood clots. And if it's has like impaired clotting, then that might indicate that he has a higher risk of bleeding. And then I put a question mark next to lumbar puncture. This is a procedure that is sometimes done to work up certain neurologic symptoms, especially if we want to rule out something like meningitis. But it sounds like this patient, it's not as likely that he has meningitis. And a lumbar puncture does also carry additional risks, like infection and bleeding and things like that. So, and like Chase said, he has neck stiffness, which is one of the signs of meningitis, but doesn't have a fever. And we'll see on his CBC if he has like an elevated white count or something. So this is his non-contrast CT. I'll give you guys a second to look at it, and then I'll explain kind of what we're finding in this. So right off the bat here, I want you guys to get oriented. So the patient, the way we look at it is imagining that the patient's feet are coming out towards you and you're looking straight at them and they're on their back. So this top part here is going to be the most anterior, like their forehead. And then this is the back of their head. And then what we see on the left of the image is actually going to be the patient's right. So it's kind of backwards for us, but if you think of somebody like laying down in front of you with their feet coming out, like then that would be their right side. And then this is their left side on this side. And the thing that we're seeing in this image is this sort of star-shaped appearance that's right in the middle of the brain and kind of a lighter color than the rest of the brain. Obviously we see this really white structure. This is the skull, which is going to enhance really brightly on a CT. But the rest of the brain normally has this sort of gray, sort of different shades of darker and lighter gray. And then this really lighter stuff in the middle is actually blood, filling up the space where the cerebrospinal fluid is supposed to be. And this is also kind of outlining where the circle of Willis structures are going to be found as well. So this is really concerning for a brain bleed in this area. And the space that the area that we're seeing it light up is in the subarachnoid space. So this is the rest of his results. The CT angio is pending. The CBC pretty much looks entirely normal. He does not have an elevated white blood cell count. Red cells and hemoglobin are normal, and his platelets are normal. For his BMP, or the basic metabolic panel, his sodium is a little bit on the low end. The normal range, I guess I should have put this, but the normal range for sodium is 135 to 145. So he's just right on that sort of borderline of it being a little bit low. And then his BUN is also slightly elevated and his creatinine is high. So BUN and creatinine are both kidney markers and markers of your kidney filtration function. And so with these being a little bit elevated, we would maybe suspect that he also has some underlying kidney disease. But that really doesn't tell us much about his neurologic problem. And then his lumbar puncture, again, probably wouldn't actually have to do this in real life, but it showed many red blood cells with no bacteria and no white blood cells present in his cerebrospinal fluid. And then for coagulation labs, they were all within normal limits. So it didn't appear that he had any like blood clotting problems. Okay, moving on to our assessment and plan for this patient. We have a 44-year-old male with a history of hyperlipidemia on simvastatin who presents with a sudden onset thunderclap headache with a 20-minute duration and has no identifiable cause or trauma. The exam reveals minimally reactive pupils and an impaired awareness on mental status exam. His non-contrast CT revealed a high density in the subarachnoid space, which is consistent with an acute spontaneous subarachnoid hemorrhage. So I don't remember who said it at the beginning, but we did have that on our list on our differentials. So good job, everyone. And our plan for this patient is going to be to admit him to the ICU for close neurological monitoring and medical management. So I know that was a lot of information. I just wanted to give you guys the opportunity to ask any questions about the case, or if we needed to go back to any slides for you to finish any of the SOAP note sections before we move on. Yeah, and also I think we said that we would do a neuro consult. Yeah, it looks like someone raised their hand. You can unmute or put in the chat whatever you're comfortable with doing. Okay, well, if we don't have any questions, then I'm going to move on, but we can always go back if something comes up later. Actually, someone might be talking and I need to make sure my sound is on. Okay, I don't hear anybody. All right, so this is his CT angiogram that came back after we, it did our admission and everything. And it's basically showing an aneurysm of the right internal carotid artery. So this is a coronal view where we kind of take a slice going down the center of the head. And then again, the patient is facing us. So this is going to be on the patient's right side, even though it's our left. And you see this giant kind of ballooning bubble-like structure that's coming off of this artery here. This is the internal carotid that's coming up. Kind of would be the neck down here. It's coming up kind of through the neck and the back of the head. And then it kind of does this loop around and has this giant aneurysm. And then you can also see that there's not as much blood flow in these surrounding areas because the aneurysm presumably has, had a leak in it and burst. And so this is just showing a couple of other angles of it, but it's helping us basically identify where the initial bleed came from. Oh, looks like so Tamahina, I'm sorry if I'm saying your name wrong, asked how would his high cholesterol cause a subarachnoid hematoma? And that's a great question. So it may be related, it may be a risk factor for that. Particularly if he has a lot of plaque buildup in his arteries in his brain or elsewhere in his body, then that can sometimes weaken the walls of the arteries and cause an increased risk of aneurysms as well. And so having an aneurysm is definitely going to be a higher increased risk of a subarachnoid hemorrhage, but they don't have to be directly related. You can have just like a high cholesterol because you have a poor diet or because you are just genetically predisposed to having a high cholesterol, and you never have any neurologic consequence of that high cholesterol. But there are certainly, like especially for ischemic strokes, high cholesterol can cause buildup of plaques in the arteries that go to the brain, can either block those off and prevent blood flow from reaching the brain, or like I said, they can weaken the walls of the vessels and predispose you to having aneurysms. So that's a great question. But I think it was mostly just to give him a little bit more interesting past medical history. Okay. So like I said, we can always go back if we need to, but I'm going to have us keep going. So risk factors for brain bleeds. We talked a lot about trauma as being a risk factor or a cause for brain bleeds. And this one, I think you can probably assume that like if you have a direct blow to the head, or if you have a traumatic event to the head, your brain, has a skull surrounding it. So that's designed to protect it. But you can still have like inertia and things that cause the movements within your brain to have shearing forces and can disrupt the walls of especially already weakened blood vessels. So that's the number one risk factor for brain bleeds. The other ones are age. The older you are, the weaker your blood vessels can be, and are more susceptible to bleeds. Hypertension, especially high blood pressures over the range of like 190 systolic, is like the one that we kind of throw around. So it's very, very high and uncontrolled. That can cause brain bleeds just by nature of you have so much pressure going to your brain and the blood vessels in your brain that they just can't accommodate that pressure anymore, and they can just burst. And then being on medications like blood thinners that have properties that prevent you from being able to clot your blood properly, or if you have like a genetic coagulopathy. So for example, like hemophilia, or there's some other ones like von Willebrand's disease that tends to be a more mild one actually. But if you have a impairment in your clotting system, then you can have more easy bleeding. Particularly for subarachnoid hemorrhage, male versus female slight predominance, or males slightly higher rates than females, but it's not a super big risk factor. And then lastly, certain genetic conditions can predispose you to having vascular abnormalities. So one that they love on our board exams to ask about is autosomal dominant polycystic kidney disease. You're like, what, the kidneys, what does that have to do with the brain? But something with the genetics of your having a polycystic kidney disease can also increase your risk of having aneurysms. And they are called berry aneurysms because they look like little berries growing off of a vine or something. And those, especially if they happen in your brain, like we talked about, weakening of the wall can predispose you to having rupture of those aneurysms and brain bleed. Certain hypermobility disorders, some people, I don't know if you've ever heard of Ehlers-Danlos syndrome, but there's a specific subtype of Ehlers-Danlos syndrome called vascular Ehlers-Danlos syndrome, or VEDS. That is a like collagen mutation, and that can also weaken the wall of your blood vessels. And then lastly, some neurocutaneous disorders that can cause increased risks of arteriovenous malformations, where you have, it's kind of a spectrum of them, but you can have either veins that closely connect with your arteries and they have this really high pressure system that's going into your veins, but they're not supposed to do that. Or if you just have like structural problems with your vasculature in your brain, that can certainly also be a risk factor for brain bleeds. Most brain bleeds are going to present with the symptoms of headache or altered mental status, change in consciousness, things like that. Those are kind of the three primary things that we would see. Depending on the severity of the brain bleed, like you can just have a headache and it is kind of mild and nothing really ever gets worse than that. Or you could like completely lose consciousness and go unresponsive and go into a coma and like die from it. So there's a huge spectrum of symptoms in presentation of brain bleeds. Secondary symptoms to more so having like an increased mass in your brain. So normally you have a very controlled intracerebral pressure, which is made of like your own brain tissue, your cerebrospinal fluid, and your blood flow in your brain. If you have too much blood getting into your head because you burst a blood vessel and it's now being flooded with all of this blood, then you can have what we call like mass effect symptoms, which would be like nausea and vomiting, photosensitivity, which is like aversion to bright light, and neck pain, which is that meningeal sign that we think of. So these all can kind of also mimic meningitis, which is going to also be like something that causes an increased pressure of the brain. And those are generally more poor prognostic signs because you are compressing parts of your brain that are not, supposed to be compressed. It looks like Chase is asking about if you have decorticate versus decerebrate posturing. Yeah, so that's part of like in the Glasgow coma scale that we would have as a motor sign. When you are really, really like severely neurologically impaired, you can have interesting posturing where you're either like have your limbs and your posture is just very flexed. That one I think is decortic. I can never remember the two, but one of them is like you're flexing everything, and the other one is you're like extending out your arms and legs, and your neck is kind of rolled back. That one's the worst one. I'll tell you that the one where you're extended is worse than the one where you're flexed. But yeah, I think it's decorticate is the flexion one, and the decerebrate is the extension one. That was a tangent. You guys don't have to actually worry about that. But then, so yeah, that's the presentation of brain bleeds typically. The workup that we would do for someone with a suspected brain bleed is to always check their vitals, do a thorough neurologic and mental status exam, and always get their non-contrast CT, which is again that gold standard for the initial diagnosis of a brain bleed. The CT angio is going to be like more specific to be able to show the source of a brain bleed, but it's not the first line because again, it takes a longer time to do it, and we want to get answers like right now. And for prognosis of brain bleeds, it does vary by type that we went through the 4 different types of the brain bleeds that we're focusing on today. But for our patient who has a subarachnoid hemorrhage, it's usually a very, very poor prognosis with an up to 50% mortality and a very high morbidity and disability rate in those who do survive a subarachnoid hemorrhage. So very, very scary stuff. Something that you really don't want to have. So we're going to first go through the 4 different types of brain bleeds that we talked about previously, starting with an epidural hematoma. This is going to be a lens-shaped enhancing lesion on CT, or this convex lens, where you have usually on just one side of the head, something that is kind of this like oval shape, I guess, of hyperenhancement. This is all blood collecting. And I should have put like for anatomy of the meninges layers, but so you have your dura mater, your arachnoid mater, and your pia or pia mater. And so the epidural hematoma is going to be in the space above the dura mater, but below the skull. And so you're going to be compressing all of this brain tissue here that's like supposed to normally go up to the edge of the skull. This is all getting compressed back. And you can see that it's causing this, what we call a midline shift, where this is the corpus callosum here, and it's supposed to normally go right down the middle. And these black spots here are the ventricles of the brain, which are filled with cerebrospinal fluid. You're supposed to have it look symmetric. It's supposed to have everything be nice and equal on both sides. But because we've got all this compression of brain tissue back on this side, it's pushing things across the midline, and we're losing structures that would normally have symmetry. So that's a very bad sign. This is almost always caused by trauma, and this is also highly associated with skull fracture. So in these patients, it's a good idea to also get a head x-ray, because as you can see, like the bone does not really have any detail to it here because it's so hyperenhancing. So you can have a head x-ray to be able to show if you have a fracture in the skull. And the underlying mechanism for an epidural hematoma is a tear of this middle meningeal artery here. I don't know if there's like a good way to remember that, but this is the main artery that is affected in an epidural hematoma. And this is the one, like I mentioned before, that can present with a lucid interval where your patient can feel totally fine initially, but then, shortly after they have increased symptoms or a change in their mental status. And we talked about the midline shift and the treatment for epidural hematoma. This is a neurosurgical emergency. So the treatment is going to be a craniotomy, which is where you open up the head and evacuate the hematoma, which is like either using suction or I don't know. I've never actually done neurosurgery before. So they somehow remove the bleed. That's what they do. Subdural hematoma is going to be one step underneath the layer of that dura mater. So instead of having it be pressing up right against the skull, the dura mater is going to be next to the skull where it's supposed to be, but then the bleed goes underneath it and over top the arachnoid matter. So we have a characteristic crescent shaped enhancing lesion on CT. You kind of see it looks like a crescent moon here a little bit. And the cause of this is going to be a tear of the bridging veins in the meninges. So remember, the first one was middle meningeal. The second one is bridging veins. Usually this is caused by trauma, but we see it a lot more in elderly people who have like minor falls, who it doesn't have to be like an intense head trauma, like it can just be something really minor. And especially older people who are on blood thinners and anticoagulants. That's going to be a big risk factor for this type of a brain bleed. And because the spectrum of what causes it is kind of so broad, these can be either acute or chronic. So this one is an acute because we see a lot of this bright colored blood here. But you can also have a patient who's maybe had an old one that they didn't even really have that many symptoms of. Maybe they just had a minor headache and it kind of self-resolved. So it would look like a lot less severe and it would be kind of a different color on imaging compared to an acute. So the guidelines for treatment for this are kind of dependent on how big it is. If it's small, without signs of compression of the brain, like this one doesn't really have any significant midline shift, like maybe there's a little bit less of a ventricle going on here, but also it's not a great picture. And this, it's probably dependent on the section that we cut through of the brain. So I wouldn't even call this a fair comparison, but I would say in general, this is probably a not super severe one. And then if it's greater than 10, also this is totally meant to be millimeters, not centimeters, I think. I'll have to double check that, but if you have a larger one with signs of compression, then you would need to go in for surgery. So this is the same one that our patient had, a subarachnoid hemorrhage, and we have a characteristic star, death star, I guess, appearance of the bleed on our CT scan. So again, we're going to see this sort of star-shaped appearance where the cerebrospinal fluid would be flowing. And you can kind of see it in these other spaces too. And this is in between the gyri or the folds of the brain where it kind of, looks like that has a bunch of like weird bumps and folds on it. And it's your whole brain is bathed in cerebrospinal fluid. And it's all continuous with the entire network that it has of cerebrospinal fluid. So that's why, if you remember back when we like had a lumbar puncture on this guy, that he had like a lot of red blood cells all the way down in his spinal column. And that's because your cerebrospinal fluid will also go all the way down into your spinal cord, and can be accessed on a lumbar puncture. So anywhere that there's CSF, you can see bleeding in this type of a hemorrhage. Generally, it can be a lot of different places, but I just wanted to emphasize that this can be the circle of Willis because really that's what we're seeing highlighted in this star-shaped appearance here is where the circle of Willis would be affected. And this is, again, it can be due to trauma, but a lot of the times it's also spontaneous, which is usually caused by a ruptured aneurysm. And the risk factors for aneurysm would be like hypertension, smoking, drug use, maybe also high cholesterol, like we kind of talked about earlier. This one has a very high morbidity and high mortality. It's a very not good brain bleed to have. And surgery is not usually an option with these patients because it's like the location of where the bleed occurred is so deep inside the brain. It's not like accessible through surgery. And so a lot of the times the patients will only be able to receive supportive care through managing their blood pressure, giving them IV fluids, and making sure their electrolytes are in balance. Like if this guy had a low sodium, that we'd make sure that we're giving him some sodium replacement to keep that where it needs to be. And then doing frequent neuro checks to just be monitoring for any significant changes. The last one that we talked about was an intraparenchymal hemorrhage. A lot of the time, this is the same as or due to a hemorrhagic stroke. And this type of stroke is a lot less common than ischemic strokes, which is the more classic strokes that we think of. This ischemic stroke type is going to be about 80% of all strokes, and hemorrhagic is going to be like 20% of strokes. The biggest risk factor for an intraparenchymal hemorrhage is severe hypertension. So a systolic blood pressure over 190 is going to be really concerning that you can stroke out. We want to get that blood pressure under control as soon as possible, as well as trying to keep the pressure in the head down by having your head be elevated. So we don't like to have these patients be like laying flat on the bed. We'll keep their head of the bed like at 45 degrees to try and reduce the amount of pressure in their head. Complications of intraparenchymal hemorrhage can be something like seizures, neurodeficits in whatever area is affected. So this is probably a little bit advanced, but the area that's affected here is probably the basal ganglia, which is a big motor control center of the brain. And given that this is on the patient's left side, he might have some left-sided motor problems. But again, that's pretty advanced. I wouldn't expect you guys to know that or to remember that. And the treatment for an intraparenchymal hemorrhage is to control the cause. So if their blood pressure is still high, like make sure that you lower their blood pressure, especially if they're over this 190 threshold. Like that's a very severe range. If they're in the 200s, like bring them down. You can also do supportive care, like we mentioned before with the subarachnoid hemorrhage, like IV fluids, things like that. And then you can also consider doing surgery. If their pressure is really high in their brain still, you can do like a burr holes or something to try to relieve the pressure by removing part of the skull and letting the brain swell out, and then recover to try to prevent further like compression of the surrounding brain structures. So just to summarize, like the types of bleeds and what you would see on a CT scan, epidural hematoma is going to be a convex lens, this kind of like weird oval shape. This is the best that I could find on Google Slides because I made these shapes myself. Subdural is going to look like a crescent shaped lesion. Subarachnoid is going to give us that star shaped lesion. And the intraparenchymal is just going to kind of look like that weird like cloud-ish looking thing here. It's not really a cloud. I don't know. Whatever, it's the odd one out, I guess. It doesn't really have a specific thing. So a quick patient update, because I like to have closure with people. Our patient spends 2 weeks in the ICU on subarachnoid hemorrhage protocol, and he does struggle with seizures and hyponatremia or low sodium throughout his stay in the ICU, which we manage with medications. And while recovering from his brain bleed, he is placed in a medically induced coma and is also intubated and is breathing on a ventilator. While he's in the ICU, you, his doctor, are managing his ventilation, his nutrition, hydration, and his other medical conditions and organ systems. So trying to make sure that we are looking closely at his kidneys, because if you remember, his kidney labs on the BMP were a little bit off. And just making sure that everything physiologically is staying stable or trending in the right direction during this stay. We're also the primary contact person for family members and give them daily updates on his condition and his progress while he's in the ICU. And eventually he is able to be taken off of his ventilator, not in a coma anymore, and he is stable enough to be transferred to an inpatient rehab facility for physical and occupational therapy. So again, like it's not uncommon that patients who have these types of brain bleeds have a lot of morbidities or disability following them, and they have to regain their strength and relearn how to do things that they may have lost in this process. So it's a pretty devastating diagnosis, but the fact that he survived it is honestly like pretty good. The last thing that we have for today, because I always like to do a little about this specialty segment in virtual rounds so you guys can have some exposure to the different specialties. And I wanted to focus on just critical care and ICU physicians. I know this is a lot of neuro that we did, but I've done like neurology talks in the past. I don't know if you guys have were like around for those. I think they're on YouTube if you're interested, but we haven't really had like a designated critical care one. So basically ICU physicians are master coordinators of all elements of patient care. Like, so they take care of every body system and like problem that a patient could have. And they work very closely with and collaborate with a lot of specialty physicians. So like someone was saying in the chat earlier that one of the things we would do is consult neurology to make sure that they are also on board with managing this patient. That's their area of expertise. Maybe we would consult nephrology for this patient's kidney function or something. So we're going to work with a lot of different types of doctors to make sure that this patient is getting excellent care. ICU physicians are also able to perform a lot of different kinds of procedures. Some ones that I thought of off the top of my head were intubations, bronchoscopies, central lines, chest tubes, point of care echocardiograms, and point of care ultrasound, lumbar punctures, and honestly, so many more that I could probably just make an entire presentation on, but they do a lot of bedside procedures. Critical care doctors, you know, they see patients when they're really at their sickest and at their worst, and when people might not know if they're even going to make it through. And unfortunately, you know, a lot of their patients don't make it. And so ICU physicians can also be a part of transitioning patients to end of life care while they're in the hospital, and maybe even helping them become organ donors. And then, of course, having relationships with family members during these really difficult times when the patient's sedated or they're in a coma or something, and they can't actually get updates on their own status. But a lot of the times we have family members or loved ones who are the primary kind of point of contact that we have to provide updates and things like that. So ICU physicians have to have excellent communication skills and excellent like empathy abilities and things to have those close relationships with families and loved ones. And then just if you're curious about the lifestyle of a critical care doctor, it's almost exclusively shift based. It's rare, like I don't think they would ever have clinic unless you also like you specialize in something else. Like if you're, say, a general surgeon and you have general surgery patients that you follow in clinic, but then you also like work in the ICU like on the side, I guess. But if you're just specifically an ICU doctor, like you wouldn't have any clinic, you would just do shift-based inpatient work. Some downsides would be that, like, you know, your patients, once they are good enough to move out of the ICU, it's very rare that you would have follow-up about these patients and how they ended up doing, unless, you know, they choose to stay in contact with you and provide you with updates. But it's not like in other specialties where you would be able to see them in clinic in like 6 months or whatever, you know. And as you can imagine, this type of work is very intense and emotionally demanding, but it also can be extremely rewarding. So the most profound experiences that I've had as a medical student were in the ICU with some really like just devastating cases, but you really do have like a huge impact on these patients and their families. And a lot of the times people do pull through and they end up doing really well. So to see people beat the odds and go on to have, you know, their lives back is a really amazing thing that you get to see. So how would you become a critical care doctor? There's a lot of ways, luckily. So they all start with you going to medical school, which can be either an MD or DO. One of my letters of recommendation for residency was with an ICU doctor who was a DO, and he was amazing. And our clerkship director, and he was the director of the like hyperbaric oxygen unit in our hospital. Very cool. But you can almost do, I would say that critical care doctors, like you have the most flexibility in your residency training and with the eventual like end goal of getting into the ICU compared to like any other specialty. So you could do things like internal medicine or pediatrics, which are only 3 years long, emergency medicine, which can be, I would say mostly 3, but sometimes you have 4-year programs, and then anesthesiology, which is 4 years, or surgery, which is 5 to 7 years. So that's like just right there, 5 different residencies that you can do, and all of these people could work together and both or and all be in the same ICU taking care of patients next to each other. The one thing that you'd have to do is do a critical care fellowship after your residency, or sometimes during your residency. That is also a possibility, especially for surgery because they're so long. But their critical care fellowship is going to be 2 to 3 years long, especially if you do internal medicine or pediatrics. Sometimes your fellowship is combined with pulmonology, so then you're double board certified in critical care medicine and in pulmonary medicine. And then, like most other things, you can further subspecialize into different like organ systems or problems that patients have. So you can like only work in the cardiovascular ICU or the neuro ICU or a surgical ICU or something like that. And if you are one of the people who are, maybe interested in doing medicine and going to medical school, but you aren't 100% sure on it, and maybe you are like considering other things like nursing, you can still work in the ICU and be a critical care provider as a nurse practitioner, which would be a 3 to 4 year DNP or Doctorate of Nursing Practice program after you get your BSN or your Bachelor's in Science in Nursing. And then additionally, a physician assistant can work, or a physician associate. I think they're changing the name of PAs now. So I just included both because I don't know which one to use. But PAs and NPs can also both work in the ICU alongside of the ICU physicians. So a couple different ways to get into critical care if you're interested in that. These are my sources from our presentation today. And I just wanted to double check and see if anybody had any questions. If not, then I'm really happy that everyone came today. I hope that you learned something about brain bleeds or about becoming an ICU doctor. And please let me know if you have questions. I'd love to chat with you. How I typically do this is I'll just like stay on for you guys to either start on the quiz, or if you have questions about applying to med school or being in med school or anything, even if you have like a question you want to talk about at the end in private once everyone's left, I'll just kind of hang out here until people start trickling off the call. So feel free to sign off at any time. Chase is asking, are there no integrated ICU residencies yet? That's a great question. I don't know if there's programs that like are combined in the sense that you become you do your residency and you tack on like a year or two of being a critical care fellow. But I said in surgery earlier, like after, I want to say like maybe your 3rd or 4th year of surgical residency, you can pause your residency training and do your ICU fellowship in the middle of your residency and then go back to finish your residency. I think that's unique to surgery because they, again, have such a long pathway in their training. And it's kind of like, instead of doing a couple of research years, so like it's not uncommon in general surgery residencies to have a year or two of a research block built, or a year or two of research built in. So if you didn't want to do research and you wanted to do fellowship anyways, then you could possibly just do your fellowship during those research years, if that makes sense. And yeah, so those providers then would probably specialize in surgical critical care. So patients that have like significant transplants, like heart transplants, lung transplants, liver transplants, trauma cases, so trauma surgery, and patients that have to be in the ICU following a trauma. You can take care of them in like every stage of their hospital admission. So you can not only like be the one to operate on them when they initially come in, but then if they're in the ICU afterwards, then you can have the ability to care for them while they're still in the ICU. So, yeah, I think like you can do a designated trauma fellowship after surgery, or you can do a critical care fellowship after surgery, but in both cases, you would be like caring for trauma patients. Yeah, it is a really cool pathway. The amount of training it takes to get there and the lifestyle and this just the cases that you have as a surgical critical care physician is obviously going to be a very intense life. But we have a really amazing like group of people that that's their calling, and that's what they want to do, and that makes them like feel happy and fulfilled in life. So it's not for everybody. Like clearly for me it's not. I am doing anesthesiology for residency, so I will have the option of being an ICU doctor at some point, but it's definitely not like at the forefront for me, and I like more so having the flexibility. Great question. Any other questions about ICU stuff or med school stuff or pre-med stuff at all? I feel like my face is looking really red on this camera right now. Don't know why. Am I interested in a fellowship? I think if I did a fellowship for anesthesia, it would either be peds or obstetric anesthesia, actually. I really enjoyed my OBGYN rotation and being in labor and delivery specifically. And you can certainly care for the obstetric population as just like a general anesthesiologist. But if I ever wanted to be at like an academic hospital long term, then I think it'd be more likely that I'd have to do a fellowship in OB anesthesia. But again, that's one of the things I liked about anesthesia is the like I can work in a regular OR and then jump over to the labor and delivery floor and do some epidurals and some C-sections, and then maybe work with kids another day, or maybe do like a couple days, like if I needed to help out in the ICU or something, then I'd have training for all of those things. And to be able to do them all in the same like hospital, I'd probably be more in like a community or a private practice setting. So wouldn't necessarily have to do fellowship for that. Oh, Diana's asking about any advice to get into medical school. I think that just by you guys being here tonight on a random Wednesday when you could either be, out with friends or working on other homework or things, shows a lot of initiative and interest and passion for medicine. And so to continue to show your involvement and your passion through activities like this, whether it's shadowing in person, volunteering in a hospital, anything that you can get clinical experiences and show that you like working with patients, and FaceTime with doctors who can potentially get you letters of recommendation, or just give you advice on how to get into medical school and maybe some connections with medical schools. Those are only going to be positives to your application. And they generally also make you feel like what you're doing is actually worth it. Because for me, like when I was stuck in the world of general chemistry or biochemistry and all that, and I would be like, oh my gosh, what the heck am I even doing this for? But then I would take like a weekend to shadow somebody, or I would volunteer at the hospital and get to work with patients. Then it kind of reminds you why you're doing this and helps you sustain your workload throughout the entire process. Chase said that he's a pre-med and pre-med and undergrad. Is it possible to do research remotely? Yeah, I think it absolutely is possible. University hospitals being 2 hours away. I think especially in the age of COVID, that you're likely going to have more like clinical research opportunities remotely. So things that would maybe be like chart review or literature review, all of that stuff can be done almost exclusively from a computer. And so if you're interested, I know you said you have a university hospital 2 hours away, but I would maybe just like look on the website of of faculty there who are active in their publications and research, and email them or email someone from the department and just say, hey, I'm interested in getting into clinical research that I can do from home, whether that's chart review or literature review or something like that. Is there anyone in the department looking for like a research assistant or someone to help with this kind of work? Generally, that's like people really desire extra help with those things because it can be very tedious and labor intensive for people who are already doctors or who are in their residency or medical school like we. That's just kind of part of doing clinical research, so it has to be done, but to have someone have that be like their designated task might be a desirable thing for them. So I would say, like, if you're willing to volunteer and do it, if not, like, if you could get paid, that would be even better. But just to see like who's open to it, and just put out some feelers and maybe email some people and see what you can get. And I guess if you're going to try to just do it remotely, then why limit yourself to just the one that's close to you? You could look at some other places in, I guess, wherever, like in your state, or if there's a specific school that you're interested in going to medical school at, then you can reach out to them and be like, hey, I really want to be a medical student here and I want to get involved in this. Is there anyone who I can be in touch with? And they might be able to also connect you to stuff. Great question. And good luck with that, by the way. Diana's asking, what was my undergrad major? So I did general biology. I feel like I picked it for the right reasons. It just sounds boring now that when I say it, because I feel like a lot of people do biology. But I did general biology, and I also did a minor in theology. I was at a Jesuit Catholic university, Loyola University, Chicago. And so I had to do a bunch of like gen eds and humanities courses to graduate anyways. And I took a theology class in my first semester and I really enjoyed it. And I felt like it complemented my science education really well. So I ended up doing a minor, and it's actually been super helpful. I think in even now as a medical student, I've continued my involvement in the humanities, and I am doing a project on theology in medicine and surgery with like an emphasis on human pain, suffering, and healing. So it's definitely like, I would just encourage you to major in something that makes sense. So like what's going to allow you to complete what you need to do for medical school and to succeed on the MCAT. But then also don't be afraid to either add a minor or something in an area that is unique and that is something that you're passionate about, because that will help you stand out to medical schools, and it will also enrich your own personal education and kind of break things up and make things more interesting.